With this last folder in the respiratory system, we're going to get into talking about a couple of different lung diseases. So this allows you to kind of synthesize everything that you've learned up to this point and put it together to see how these things that we've learned and that we've talked about can be used clinically in a situation where somebody has been diagnosed with a lung disease. So there are two different types of lung diseases, two kind of broad categories that lung diseases can be classified into. The first of these are what are known as obstructive lung diseases. And when somebody has an obstructive lung disease, basically what that means is there is airway obstruction, and that makes it difficult for them to exhale and often also to be able to inhale as well. Probably the most well-known, very common example of an obstructive lung disease is asthma. And that's what we're going to look at with our activity on this particular type of lung disease. We're going to look at an asthma attack that happens in a pediatric patient. Emphysema, we've talked about previously. It's a good example of an obstructive lung disease because it also, for the reasons that we talked about, makes it really difficult to be able to exhale. Chronic bronchitis, where you've got inflammation of the airways, which is swelling, making those airways smaller than they normally would be, is a good example of an obstructive lung disease, as is cystic fibrosis, where the airways actually start to fill up with mucus, and that mucus blocks the pathway of air, making it difficult for people with this particular condition to breathe. Restrictive lung diseases are a little bit different. The difficulty with these is primarily with inhaling, and this is due to lack of lung compliance. So what I mean by that is the lungs just aren't stretchy. They don't open up like they normally should to allow air to enter into the lungs. So we're going to look at a condition with our activity in this folder, which is known as interstitial lung disease, or ILD, that has a lot of different causes, potential causes. But one of the things that happens with this particular condition is the lungs start to fill up with scar tissue, and that makes them less compliant. So they're not as good as opening up to inhale. And because you've got the scar tissue that's building up in the lungs where that simple squamous epithelium used to be, it becomes very difficult for a gas exchange to actually occur just because the respiratory membrane is actually physically thicker. If you're familiar with scoliosis, this in extreme cases can cause a restrictive lung disease. So scoliosis is a curvature in the spine. It's common. A lot of people that have it just have a minor curvature that you really wouldn't know about. Other people have a pretty extreme curvature, and when there's a more extreme curvature, that will actually twist the entire torso. And the side in which the torso twists into, sometimes we'll get some compression of the lungs, and in some cases, even the heart, which will make it hard for the lungs to be able to expand when you inhale. Obesity can do this as well, just because there's a lot of excess tissue that's putting pressure on the lungs. When I was pregnant with my son, he was laying transversely and really high for most of my pregnancy. And I remember the further along I got, the more difficult it became to breathe. And I often felt like I was out of breath just because he was so high and my diaphragm really couldn't contract down well in order to allow me to be able to breathe. So I want to talk about a formula that allows us to be able to calculate airflow through the respiratory passageways. You've seen this formula before, so it's the exact same formula that we use to calculate blood flow through a blood vessel. Basically, the formula is this: airflow, or F, so this is the volume of air that's moving through a passageway, is equal to triangle P. So this is the difference in pressure. And when we're talking about a difference in pressure, obviously we've got to have two pressures. So the difference in pressure between the atmospheric pressure, which you'll remember is the pressure outside of the body, and the intrapulmonary pressure, which is the pressure that's inside of the lungs. So F is equal to this triangle P, or difference in pressure, divided by what's known as the resistance. So resistance is what's opposing that airflow. Resistance, when we were talking about blood flow, could be things like vasoconstriction, which is going to make just a smaller lumen for blood to actually move through. It could also be something like the development of a fatty plaque in a blood vessel that's going to partially occlude that blood vessel and make it more difficult for blood to actually move through the vessel. So those are things that would increase resistance in a blood vessel. The same types of things would increase resistance in a bronchiole or in an air passageway. So we have bronchioles that are very capable of dilation and constriction. When they constrict, this is known as bronchoconstriction, and that's going to decrease the lumen or decrease the opening in the respiratory passageway, making it more difficult for air to actually move through that respiratory passageway. So that would be an example of something that would increase resistance in the lungs. With certain conditions, and asthma is one of these for sure, you also get inflammation, which causes swelling, which would tend to increase resistance because it's decreasing the lumen of a respiratory passageway. But another thing is, with a lot of illnesses and with a lot of respiratory conditions, anytime you have inflammation, you have that swelling, remember that you get an increase in mucus production as well. So you get mucus actually being produced and released into the respiratory passageways, and this is going to partially occlude those respiratory passageways, increasing resistance and making it more difficult for air to move through the respiratory passageways. So we've got a couple more slides with this particular lecture, and what I want to do with these last two slides is introduce you more specifically to the conditions that you'll be looking at in the activities that you're doing for today. So with this first slide, I want to orient you to asthma and what's going on with people that are asthmatic specifically. If you look at this picture that I have over here, I've got two examples of bronchioles. So the lower one, you'll notice, is labeled normal bronchiole, and you can see that there's a nice open lumen for air to be able to move through during inhalation and exhalation, and that means there's not going to be a lot of resistance to airflow. For people that are asthmatic, they have this underlying inflammation of the lungs and of the respiratory passageways. So that causes, due to this underlying inflammation that's always there, it causes swelling of the respiratory passageways. So if you look at this upper picture here of an asthmatic bronchiole, you can see the artist is trying to represent that swelling, that inflammation. There's redness there, but just the swelling itself tends to decrease the lumen, so that increases resistance to airflow in somebody who's asthmatic. Anytime we have inflammation, you guys also know you get an increase in production of mucus, and so you can see represented there in yellow some mucus that is building up in those respiratory passageways, and that's going to further occlude the respiratory passageway and make it difficult for air to get into the lungs when you're inhaling, but also difficult for air to leave the lungs when you're actually exhaling. So there's this underlying condition in people that are asthmatic that isn't seen in people that are not asthmatic. If you know somebody who's asthmatic or you are asthmatic yourself, you probably take a daily preventative medication. So this is a medication that usually you take 2 puffs of in the morning, 2 puffs of at night. And the role of that particular preventative medication is it helps to mitigate this inflammation, the underlying inflammation that's there. So it's going to decrease the swelling, it's going to decrease the mucus production that asthmatic people normally have. The kicker and the thing that happens that causes a severe asthmatic exacerbation is you get bronchoconstriction on top of this airway inflammation and swelling and mucus production. So people who are asthmatic, people who are not asthmatic, we all have situations that cause our airways to dilate. We all have situations that cause our airways to constrict. Just as an example, if you breathe in really cold, dry air, that's going to cause constriction of your bronchioles, whether you're asthmatic or not. If you're not asthmatic, that's not a big deal because you don't have additionally mucus and inflammation and swelling that's going on. If you are asthmatic and you have this swelling and this inflammation and this mucus that's in your lungs as well, and then you get a bronchoconstriction on top of that for any reason, that can lead to a very severe asthma exacerbation. And that's what an asthma attack is. It's basically bronchoconstriction with swelling and mucus present, which, depending on how severe the exacerbation is, can range from mildly uncomfortable to life-threatening and actually lethal with an asthma attack. So we talked about that formula that calculates airflow through the lungs with the previous slide, and I've got that formula here again. So just as a reminder, airflow into and out of the lungs is equal to the difference in pressure. So that's the difference in pressure between the atmosphere and intrapulmonary pressure, or pressure in the lungs, divided by resistance. So normally those of us who are not asthmatic don't have a problem with resistance in the lungs. I'm going to just put some numbers in here just to kind of illustrate a point and kind of show you what happens with this equation when somebody is having an asthma exacerbation. So we talked about, when we were in the pulmonary ventilation section, the fact that what we normally need to see is a difference in pressure between atmospheric pressure and intrapulmonary pressure of 1. And once we've got that difference in pressure of 1, that allows for air to be able to move into and out of the lungs. So let's say, and again, I'm just throwing numbers out here. Let's say under normal circumstances, normal healthy person, healthy lungs, resistance is equal to 1. Okay, that's going to give us an airflow of 1. And again, these are just numbers. Here's the situation that's happening with an asthma attack. You're getting an increase in resistance. So I'm going to just throw these numbers out here again. If airflow is equal to the difference in pressure between atmospheric and intrapulmonary pressure, and we're generating what we normally generate through the mechanical movements of pulmonary ventilation, a difference in pressure between these two of 1, and our resistance has doubled, that's going to cut your airflow in half. Okay, so if you're having an asthma exacerbation, your air into the lungs is going to decrease, and it may not decrease by half. It may decrease by much less than that. It may decrease by much more than that. It just depends on how severe the bronchoconstriction is and how severe of an asthma exacerbation is. But if you look at this formula, what I'm trying to get out here is when you increase resistance, you're going to get a corresponding decrease in your airflow. So what happens for somebody that's having an asthma attack, and if you have asthma or you've been around somebody who's having an asthma attack, you'll notice that their breathing starts to become very labored. And they start to get what are known as retractions happening sometimes in their neck, sometimes underneath the rib cage, where you've got muscles that are contracting so strongly in these areas that you can see that muscle contraction happening, and it's causing skin to kind of pinch in between muscles and bones in those particular areas. What a person who's having an asthma attack is trying to do is they are trying to compensate for that increase in resistance. So without medication, they can't change the increase in resistance. It's there. What that means is the only thing that they have any control over is the difference in pressure between intrapulmonary pressure and atmospheric pressure. So they try to control this part of the equation. And if we go back to that idea, again, just throwing numbers out there, that somebody who's having an asthma attack has had their airflow decreased in half, what they can do to try and compensate for that is increase the difference in pressure. So if you think about it this way, if they're able to create a difference in pressure of 2 instead of the 1 that's normally needed, even if their resistance has doubled, that's going to compensate and allow them to get the needed and the normal amount of airflow that they would normally get. So they've got to work on really increasing this difference in pressure between the atmosphere and intrapulmonary pressure. We don't have any control over atmospheric pressure. That's set, right, based on the laws of physics for the elevation that you're at. What you can control is the intrapulmonary pressure. And if you think back to when we talked about pulmonary ventilation, the way that we manipulate that intrapulmonary pressure is by decreasing or increasing the volume of the lungs. So when we open up the lungs using muscle contraction of the external intercostals and the diaphragm, that decreases the pressure in the lungs to allow us to breathe. When we decrease the volume of the lungs, that's going to increase the pressure and help to push out air that's residing in the lungs. So what happens is people that are having a severe asthma exacerbation start needing to use additional muscles. So instead of just using the external intercostals and the diaphragm to breathe in, now they may start using the scalenes, they may start using muscles in the upper back, muscles in the chest area as well, to really physically pull very strongly on the thoracic cavity to open it up as much as possible, to decrease the volume as much as possible and get a bigger difference in pressure between atmospheric and intrapulmonary pressure when they inhale. As you can imagine, if you're having to do that for some period of time, it gets very exhausting just to breathe because you're contracting so many muscles trying to open up that cavity in the lungs enough to get air into it. The flip side of that is when they exhale, they need to, again, create a difference in pressure that's larger than normal. So that means they're going to have to really put pressure on the thoracic cavity using muscles to decrease the volume of the thoracic cavity and lungs more than they normally would have to, so that they can increase the pressure in the lungs more than they would normally have to push air out. So you'll see them as they're exhaling starting to engage muscles in the abdominal pelvic cavity. So core muscles, for example, to put pressure on the lungs from below to help squeeze those lungs to increase the pressure in them enough to drive air out of the lungs, despite that increase in resistance due to the bronchoconstriction and mucus and inflammation that's going on. So people that are having asthma attacks, it can be very exhausting for them to breathe, on top of course, being scary because they feel like they can't get what they need. So in your first activity for this week, you're going to have the chance to work through a pediatric asthma attack from the onset of that attack through a visit to the hospital, treatments that are given, how things are measured, due to follow-up and release from the emergency room. The second type of disease that you're going to have an activity on in this folder is, again, interstitial lung disease, which is a restrictive lung disease. So I talked about this one a little bit previously, but I want to use these microscope slides here of actual lung tissue to give you a little bit better example of what's happening in this particular condition. So if you look at this slide here on the left that's labeled normal lung tissue, hopefully this is a slide that looks really familiar to you now. So you can see little alveoli, little air sacs that are in there that are open, hollow spaces. And then you can see the walls of those alveoli as well, which are really thin. They're a simple squamous epithelium, and that allows air to be able to diffuse across that wall from the lungs to the blood, from the blood to the lungs, very, very rapidly in about a third of a second. And that allows for good gas exchange between the lungs and the blood. If you look at what's happening in interstitial lung disease, you'll notice that we've still got those open spaces, so we've still got the air sacs, but the walls around them have increased in size incredibly. And that's because the simple squamous epithelium has been replaced by scar tissue. And that scar tissue is not good at allowing gas exchange to occur. So if you're a little oxygen molecule and you need to move from an alveolus into the blood, you've got a much thicker tissue to diffuse through, and you're probably not going to be able to do it just because that tissue is so thick. Conversely, if you're a carbon dioxide molecule that's in the blood, you're not going to be able to diffuse out of the blood into the lungs because the tissue is so thick. So you start to get problems with gas exchange happening in interstitial lung disease, and you see oxygen levels in the blood decreasing because oxygen can't diffuse in, carbon dioxide levels in the blood increasing because carbon dioxide can't diffuse out. But because we've got this much thicker kind of scar tissue that's making up a bulk of the lungs at this point as well, it becomes very difficult for the lungs to open up, to be compliant, to actually allow air to flow into them. So you'll have a chance again in this folder to work with interstitial lung disease and get a little bit more familiar with it as an example of a restrictive lung disease.